Hi, I'm Dr. Hal Seiden. I'm a pediatrician here at BC Children's Hospital, and I'm also the medical director of Canuck Place Children's Hospice. I'm a palliative care pediatrician as well as a member of the pain service team here at Children's. Today I'm going to talk to you about management of kids with neuropathic pain, and especially the way you might encounter them in the emergency department. Neuropathic pain is a very frustrating and somewhat confusing entity, and there's an awful lot that's been written about it. It's also one of the things that's very, very hard to manage in a short-term type of setting. So what would be reasonable goals when you see typically an adolescent with this kind of pain in the emergency department? Once you've reassured yourself that there's no inflammatory cause going on or no acute injury that's occurred, and you suspect that it's neuropathic pain either by the exam or by the history, then you have to consider how medications fit into the overall long-term therapy. The therapy that we provide for kids with neuropathic pain here at BC Children's consists of what we call the 3P approach. And that stands for pharmacology, in other words medications, physiotherapy, and psychology. We explain to families right from the get-go that neuropathic pains, the kinds of pains that are not due to an acute injury or inflammation, cannot get better without all of those pieces. One of the reasons we emphasize this is because all of the kids on our program see our psychologist and see our physiotherapist along with the physicians. So they have to understand right from the get-go that the model is going to be one of engaging with multiple disciplines straight up from the beginning. The medications that we use in that setting primarily fall into two classes. One is the anticonvulsant group, and gabapentin being the most well-known of those, and the other drug class is antidepressants. Let me talk about those just for a minute in separate groups. There's some debate as to where one starts with each of the medications, and in fact in some cases medications aren't even required. But when we do use the medications, one of the things that I look for is sleep pattern. The youngster, typically, as I say, a young adolescent who has a very disrupted sleep pattern, difficulty with initiating sleep, and difficulty at maintaining sleep, I'll actually start on a very low dose of an antidepressant of the tricyclic group. So typically amitriptyline, although you can use any of the other tricyclics as your starting drug. Here we obtain a baseline EKG to look for prolonged QT syndrome, and I do obtain a history around that. And then we start on very low doses. 25 milligrams would be very usual, sometimes lower, and then go up from there. We see good effects on sleep and on pain right from the start in these kids. We also warn them about the typical side effects, typically dry mouth, dryness, urinary retention, and oversedation, and we titrate from there. When we look at the anticonvulsant group, and gabapentin, as I say, is the most well-known in that group, which has effects on sodium channels, then we are looking at less help with sleep, although it is somewhat sedating, and more help with turning down the overall neuropathic pain signal. Typically, we would use low doses starting with 100 to 300 milligrams on a once-a-day basis, and then every 3 to 4 days increasing. This is a more rapid increase than you might see in other settings. We tend to titrate this, again, towards side effects, mostly which is sedation. Most kids will end up on a range somewhere between 1,200 and 2,800 milligrams a day in 3 divided doses, but of course there's a large range around that. If you're up over 4,000 milligrams a day, you're probably seeing a drug that's not very effective for your patient, and you have to consider other avenues. But once again, I emphasize that the drugs are only provided as a component of that overall therapy, and the explanation even given starting in the emergency department before this person sees a family physician, pediatrician, pain specialist is very helpful in setting the stage for what will be the eventual positive outcome for this family. The other elements that are important for them is that the use of opiates really has no particular role in this condition unless it's being prescribed by an advanced practitioner who understands how opiates are going to help this particular patient. Generally, these pains will respond to opiates only because they're very sedating and not because in any way, shape, or form are they curing the pain or taking it away. We do find that acetaminophen and nonsteroidals such as ibuprofen can be helpful, and there's no harm in prescribing those as well. So I hope this information is helpful to you in your practice in the emergency department.